Okay, so welcome to Eat, Move, Think, the show about optimal wellness brought to you by Medcan.
Wow. Do it again.
Oh, I was practicing. Okay, ready?
Welcome to Eat, Move, Think,
the show about
optimal
wellness brought to you by Medcan.
Yeah, this is extremely good. Thank you.
Do you know this saying, the whole is greater than the sum of its parts?
I've heard it. Yes, I like it. So basically, everything together brings you more value than each of those things separately.
Yeah, so like one of those cases is Medcan.
Yes.
Okay, so let me explain. One of the real benefits of Medcan is the way that it gathers so many disparate practitioners, clinicians, medical doctors, nutritionists, fitness trainers, psychologists.
They're all in the same building.
Yeah. So it's an example of the whole is greater than the sum of its parts because they partner with you.
You come to Medcan with an issue and you have this huge range of experts who all bring their specialized knowledge to the issue. And they work together to give you an approach that makes sense holistically for your whole body.
And the truth of the matter is preventive health, which is what Medcan is focused on. It's not just about your medical health. It's not just about your cholesterol level, or it's not just about
what you
how
eat
much
in
you're
the morning.
sleeping,
No,
or whether you're exercising. It's about all of that stuff. And so it makes sense to have all these people working together to help you achieve optimal wellness.
Yeah. And I think that one of the areas where that really comes out, where that really shines, is in Medcan's pain management program. And that's for people who have struggled with severe, that really unrelenting pain that's not related to cancer for more than 3 months. That's when it's deemed chronic.
So you're talking what, like chronic headaches?
Yeah. Neck and back pain is a really common one. Chronic, just widespread pain. And then
fibromyalgia.
Yeah. Other painful conditions too. It can be pretty widespread.
The medical director of Medcan's pain management program is Dr. Michael Wansbrough.
Yes, he's a medical doctor.
He's a medical doctor who believes in this holistic approach to pain management.
Right. You wouldn't think that you need a nutritionist to treat your chronic pain, but it can really, really help.
Yeah. So he's designed a program to treat chronic pain at Medcan that features a case manager who guides each client journey through the program. But it also includes
meetings with a physical rehab specialist, a psychologist, and a nutritionist, and then they all work together to develop an individualized program of care specialized for you to find lasting relief and to help improve your quality of life.
So I'm Chris.
I'm Jazz.
We're the producers of Eat, Move, Think. And today our Move host, Dr. Andrew Miners, leads Dr. Michael Wansbrough through a discussion intended to help our listeners understand chronic pain.
Yeah, they explore why we feel chronic pain, and they describe how reframing your attitude to pain can really help mitigate your symptoms and help map out a pathway to long-term relief of chronic pain.
It's also a really funny episode.
You wouldn't think so, but editing this episode, I was laughing the whole time. It's a really lovely conversation, and they're friends, and that really comes through.
We learned a lot about pain ourselves as we produced it, how mental it is, and we're excited for you to hear it.
So in conversation with Dr. Michael Wansbrough, here's our Move host, Dr. Andrew Miners.
Hi, everyone. Welcome to Eat, Move, Think. I'm the Move host, Dr. Andrew Miners, and I'm here today with Dr. Michael Wansbrough. He's a Toronto pain physician who also happens to direct the pain management and recovery program here at Medcan and is a friend of mine. So I'm really looking forward to this conversation. Mike has studied pain for 30 years, and he has an enhanced practice designation in chronic interventional pain management and is a certified interventional pain sonologist through the World Institute of Pain, as well as an advanced diplomat in the American and the Canadian Academy of Pain Management, and is regarded as an expert in his field. And when I say sonologist, it means that he uses ultrasound to guide interventions around pain medicine, which I'm sure we'll get into later in the podcast in terms of discussion. So, Mike, welcome to Eat, Move, Think. It's a pleasure to have you here.
Thanks, Andy. It's good to be on the show.
Getting into it. So having studied pain for 30 years, why don't you tell me a bit about your background and how you got into pain in the first place?
Right. Well, my background was really in emergency medicine for a long time. And it was always a challenge to try to manage the chronic pain patients. An example of that would be the dreaded back pain chart.
Yeah.
Right.
And you want to help these people, but it's hard to do. Yeah.
You want to, but you have to pick up the chart. And really, there's not a lot to do once you rule out any medical emergencies or certain neurosurgical emergencies. So over time, I discovered that there were some tools available, and that got me interested in managing the chronic pain side of things. And from there, it was an easy segue to exploring more about image-guided procedures.
And when you say image-guided procedures, like injection-type interventions?
Sure. So ultrasound-guided injections is really what I focus on. But I also focus on trying to use that as part of a holistic care plan to improve their function and reduce their pain. It's really about improving function as much as possible.
Right. So you mentioned holistic plan or a holistic approach to pain. What does that mean?
Sure. Well, treating the whole person and not just the body part that's affected.
Right.
So using a multi-pronged approach such as exercise, nutrition, medication sometimes, although those aren't great, sometimes interventions, and one of the most important aspects, which is the power of the mind,
right,
and how chronic pain becomes centralized. And so much of the battle is with the mind, which we'll talk about, I'm sure.
Oh, absolutely. In my practice, and you and I practice together and work together, we find that a lot of times we start with treating the mind before we treat the body. And I get your frustration in the ER when people come with acute pain. They're looking for help me with my pain, help me with my pain. But what I got from what you just said is it's not about treating the pain in a lot of cases, it's about treating the person, looking at the person from a larger picture. What are the things that are contributing to why that person has pain? What's their experience with pain, their psychological profile in relation to that pain, how they're getting support at home, or how that pain is affecting their life, and all of that comes together. Is that kind of the idea?
Right. So with acute pain, somebody breaks their arm or dislocates a shoulder, and I've had a few of those personally. And so you have the peripheral pain receptors, which tell the brain, you've got an alarm going off here. There's pain that's happening. Creates some fear, which means motivates the body to get that arm out of the fire or to protect the injured part. And that's part of a normal biological protective mechanism. For if we didn't have that, we wouldn't last very long. And in fact, there's a condition where you don't feel pain. I don't know if you remember, there was a movie called The Girl with the Dragon Tattoo.
Oh yeah, I've seen it. Yeah, it's a good
and
movie.
there was one of the bad guys who couldn't feel pain.
Right.
And he didn't survive, I don't think, very long in that movie. But in reality, a lot of these people don't live to be past 25 years old. And it's because we need pain.
Because you need that alarm system.
Exactly. But an unfortunate small percent of people, that alarm system doesn't go off for whatever reason. And it just keeps firing. Even after the fire's out, the alarm keeps firing. And that creates changes centrally up in the brain and the spinal cord, which then
becomes chronic.
Becomes more chronic.
Right.
And that's a whole different entity.
Wow.
Yeah. And in fact, the World Health Organization has recently designated chronic pain as its own distinct entity, just like diabetes is an entity, or Crohn's disease is an entity.
Wow. So hopefully that'll lead to more research around just on pain. I know there is ongoing research around pain. When we have pain, does it always mean that there's damage being done?
Great leading question into this next area, which really talks about the idea that pain does not necessarily equate with tissue damage.
Right.
And, I've got two great examples, and I think everybody has examples in their own lives where perhaps the tissue damage didn't equal the amount of pain that they actually felt, or vice versa. And there was this article that I came across recently talking about this construction worker, and he stepped on a nail, and he felt this nail go through his boot. He saw it come through the other end. He was screaming in pain. His colleagues looked at him in horror, and he was rushed to the emergency department.
I have stepped on a nail, so I can attest to the fact that it does hurt.
Yeah, right. I think we've all stepped on a nail. A lot of us have stepped on nails and things, but and it does hurt. And there's a lot of pain receptors in our feet for good reason. He had to be sedated.
Wow.
He was given intravenous analgesics and morphine, and they very carefully removed this boot off of his foot. And guess what they found?
What?
The nail had actually missed his foot and gone between his toes.
So he had no injury at all.
No tissue injury at all.
But yet he was screaming in pain.
He was screaming in pain.
Now, how does that happen?
Of course, once he realized that there was no injury, it was something that could take the intravenous out and pat him on the back. And I think he was very sheepish and probably...
I'm sure. Tough construction worker.
I'm sure that he didn't live that one down for a while. But what happens there is really interesting, because all of these sensory and situational inputs to his mind registered that this is a very dangerous thing that just happened here. He's seen it before. He saw expression on his coworkers' faces of horror. He realized what the implications of this injury might be for him. Maybe on disability. He might not be able to play golf or whatever he was wanting to do. It did change his life. And all of these things flooded his system, creating this huge amount of sense of danger and fear. And this really comes into the lizard brain area, the limbic system, which is our primitive brain, which is a fight or flight or a freeze area. And all of that was designed evolutionarily wise, it's designed to be able to protect ourselves. So the brain takes over.
Interesting. I've seen studies about that where people will use mirrors, and it's used in phantom limb therapy, where research will put their hand in a hole, right? And then using a mirror, it would show their hand. So they see their hand, but they're seeing an image of their hand. And so then they can hold a lighter under the hand and people will start to perceive heat, even though the heat is not actually on the hand. It's kind of a similar idea.
And you see a phantom limb pain when you have an amputation and
they feel pain in their limb, but the limb's not there.
The limb's not there. So, but the mind still is sensitized to that. And you see that with knee replacement surgeries or hip replacement surgeries. The arthritic joint is now gone and they've got a new joint in there, but they still feel pain in that joint because the brain still has memory.
That's interesting.
So the brain's very powerful. And then there's the opposite side of things where you should feel pain, but you don't. You get it shut off because it's not in the organism's best interest to feel pain at that moment in time. And yesterday, my colleague, when I was talking to him about this podcast I was doing today, and he brought up this example where he was working in the emergency department, North York General, and there had been a fire, and this woman had saved her baby, burning her arms in the process, and brought her baby to the emergency department. It was only a kilometer away. She did not feel any pain in her arms until she actually released the baby to the care of her doctors and nurses. And then she looked down and she realized her arms were burnt. The brain has this ability to send signals down to the spinal cord to block signals from coming up. It's called the descending inhibitory pathways. We won't get into all this jargon, but it can block things. And you see it again with soldiers who are shot and they don't realize they're shot till they're off the battlefield because it's not in their body's best interests. So the brain has figured it out. They've taken all this data and they've decided, okay, well, it's not useful right now to have that whole danger, pain, fear response. We're just going to suppress things. So that gives us this idea that there is a target that we can treat. We can focus on that whole brain component of pain, which is such an important area.
Interesting. So we have the alarm system or nociceptive pain, but then we have how we perceive the pain and how we're reacting to the pain, which all occurs in the brain. And you mentioned a moment ago about centralized pain or centralized pain sensitization. Is that kind of this idea of neuroplasticity and how our brain can adapt either positively or negatively to a pain situation in chronic pain patients, like someone who's had chronic back pain in the absence of new or existing severe pathology, but still has debilitating back pain? Is that part of what's going on in those situations?
When you have tissue damage and you have acute pain, and normally within a certain period of time, everything should heal and the pain alarm system should go off. Arbitrarily, chronic pain has been defined as pain lasting over 3 months.
Which is very arbitrary, really.
It is quite arbitrary. But then the whole system moves from the peripheral nociceptors, which are these pain receptors, to a more central focus, the brain and the spinal cord. And the normal filtering system and educator at the base of the brain, which decides what's important, what's not important, that kind of breaks down. And we create new pathways to parts of the brain where we didn't really have pathways before. Back into the amygdala and limbic system, and you have this, what's used to be a nice little path, tiny little dirt path that would connect these areas. And with chronic pain, what you end up having is these superhighways start getting built. And the challenge is to try to turn those superhighways back into paths.
Gotcha. And
this is a really interesting area that Alan Gordon was an American a social worker, came up with this idea of pain repossessing therapies. And that's replacing this sense of fear and danger, which isn't there anymore.
Overriding that primitive brain response.
Overriding the primitive brain response with the sense of safety. And once you can really get that sense of safety in there and replace those danger fear responses, then you can work on decreasing the pain alarm system. And so he has a great book called The Way Out. I give a plug for him because it's a great book. And I'm trying to get all my patients to read it. The target really is on decreasing the pain alarm system, whether that's with short-term medications or with interventions, or Lidocaine Infusion, for example, can help dial down the pain response. But then once their pain levels are low enough, then you can start engaging them on other topics, other levels, physical rehab and the pain psychology side of things. And that's all of this is called the biopsychosocial approach to pain management.
You know what, your analogy of the highways versus the path, often with patients that I come in, I used a learned taste aversion as an example of how we can become oversensitive and hypervigilant to the sensation of pain and how we have these large responses to what should otherwise be a small stimulus. And I use the analogy of myself when I was a silly teenager drinking too much tequila and I made myself sick. And so
for me, it was ouzo.
And as you can imagine, there's almost everybody that has some sort of, whether it's shellfish or something that and it made them sick. And then when you think about that, or the next time you go to smell tequila, you have this strong visceral response, and almost like you're going to be sick.
This memory, this
memory, your brain
behavior.
protecting you, right? It's your brain protecting you.
Exactly.
And that's kind of what I use the analogy times with pain. When you've had this bad pain experience or this bad injury or there's persistent discomfort in your body, you become hypervigilant and aware of this. And then small stimulus, because it reminds you, like just smelling the tequila as opposed to drinking it, creates a big response, like you drank a Mickey of tequila, even though you didn't even touch it. And so I use that because the other analogy is that you can start to desensitize over time. Like I have a weak tequila sunrise when I'm on vacation, and then eventually, okay, I can do a shot. I don't order them, but if I'm at a bachelor party and I do a shot, I don't, color my shoes anymore.
I would love to see you at a bachelor party.
And so that's for that desensitization via exposure. You try to, instead of having a negative habituation, you have a positive habituation.
That's so true. I'm sure so many people out there are listening and thinking about their getting over certain things. And for me, it was rum. I had a big aversion to rum until I went to Mexico with my sophisticated Mexican friend. Said, "Oh, no, you don't drink rum like this. You need to have this Añejo rum. This is like much, much, much better rum." And once I started sipping on that, then it's like, okay, this is like now I can only drink the fine rum.
As you always should. So I use those analogies because a lot of times analogy is really important in terms of understanding a pain experience. And the biopsychosocial approach, right? As you mentioned, understanding the biology that's in presence, like what's the medical side of their pain experiencing? And then the psychological side, understanding, as you talked about, how important their perception of that pain is, like the mother who protects their baby or the construction worker who hurt their feet, how they're perceiving and experiencing that pain, how they feel about the pain, the fear. Is it going to affect my livelihood? Is it going to affect my ability to take care of my family? All of those things play a factor. And then the social side, as the biopsychosocial, it's not just about how you feel, it's about potentially how you feel others are perceiving you in the social construct, your employer, your spouse, your kids. And it gets really complicated, right? The pain is not simple.
It's very complicated. And the problem is it's not covered often by insurance or by
like psychology is rarely.
You see the pain psychologists. Yeah. And so a lot of people who are in chronic pain are on disability, they can't afford these issues anyway. So I try to steer them towards that Alan Gordon book, The Way Out. And then there's an app called Curable, which I often try and steer them towards to try and get them started. But it is so frustrating. And there's a new pain initiative from the government recognizing the importance of chronic pain through the opioid epidemic and trying to then put some resources and efforts into tackling the issue of chronic pain. Hopefully, and this is now it's called Pain Canada, and you can look that up. And I'm just really hoping that at some point there'll be some funding and some resources that'll be available in the field level for my patients, because right now we don't see any of that yet.
Right. Because it's a huge burden on society, right? In terms of cost, both personal cost and societal cost.
That's right, Andy. So 1 out of 5 people suffer with chronic pain.
1 out of 5.
So 20%, and even more than that, over 65 is one in 3 people. So you look around and you see all these people who are suffering in silence. Right? It's a very isolating condition because people don't want to advertise they have chronic pain because nobody wants to hear about it. It's like the same old. And then you get more isolated, and people think you're malingering and fearing. Some days you have good days, and then you look normal, and the next day you're in bed, and your employer doesn't know what to make of it. So it's a very complicated issue. And 7.5 million Canadians suffer in chronic pain.
Wow.
And it's costing society $56 billion.
Wow.
Billion dollars a year. $56 billion. I just couldn't believe that number.
That's a huge number. It's almost an unfathomable number how big it is.
Well, I mean, nobody really knows what that means.
A lot of zeros. Getting buy-in from the patient is important. And part of the biopsychosocial is not just about how they're feeling about the pain, because we also see with chronic pain a lot of overlay of anxiety and depression, and poor sleep. And all of these things start to cycle in and loop. So if you've got pain, maybe you're not sleeping well. You're getting more fatigued. More fatigue increases your stress hormones, and you start to become more sensitive to pain. Pain gets worse sleep. And then, you get stressed about it. Am I going to lose my job? And anxiety kicks in, especially if you've got a predisposition for anxiety, or you've been previously diagnosed with an anxiety disorder. Then that leads into more fear around the pain, which amplifies the pain. And then if you get withdrawn, or you withdraw from your family or your friends or your job, you get depression, and all this stuff amplifies. And as you're saying, in people with lower resources, it'd be a huge problem, right? It can be quite debilitating. So when you're seeing a patient like that as a clinician, outside of using those apps, if you had an ideal world, and if someone had unlimited resources, what would be the ideal approach to someone who comes in that complex chronic pain presentation? Is there an ideal approach?
I don't think there really is an ideal approach. I think the idea is to listen. I think that's really important, is listening to their story and that they're being heard, to look at whatever investigations have been done. And I think tissue damage to some degree can coexist with chronic pain, and it's hard sometimes to sort that out. So you work on both elements to try to dial down the pain. At the same time, you don't want to over-investigate more, because that then feeds into the idea that their body is crumbling.
Right, this degenerative disc disease, degenerative joint disease, and this concept of disease.
Of course, we all, it's an issue of aging, and
wrinkles on the inside in some cases.
Wrinkles on the inside.
That's what I like saying with patients.
So if you took 100 people, normal people off the street between the ages of 40 and 60, for example, and they have no pain, and you offer them a free MRI, I've heard this recently, is half of them will have disc bulges and some evidence of wear and tear, right? Degenerative disc disease and so on. And they don't have pain. And so the issue is, when you order an MRI, it comes back with these disc bulges and so on. Patients feel like, they're
focus on it.
They're disintegrating. The back is disintegrating.
I have a disc.
The whole danger, fear, pain cycle starts up. So education is so important. And again, goes back to educating patients about what they can do to help decrease that pain alarm system through the pain psychology which we're talking about, and the meditation aspects, calming the brain. The brain likes calm and it likes movement, which then calms that limbic system, that lizard brain part of the central nervous system. You want to calm that and move the focus back to the prefrontal cortex, which is our most developed part of the brain. It's our executive center. So one area that makes decisions, rational decisions. You take it away from that primitive brain and up into somewhere a little bit more conscious and sensible. So calming techniques like meditative practices, yoga, Tai Chi, and then that Qigong. I don't know if I say that properly. Qigong. I can never do Qigong.
Which is an Asian movement therapy.
Right. So that incorporates both calm and movement, because motion is lotion, they say, right? And any kind of movement is really important for the body.
So I often say with patients, what they do to themselves is going to be far more important than anything I or anybody else does to them.
Exactly.
Because often we see people coming in and they're what are called passive copers. They come in and say, "Hey, doc, fix me." Right? When in reality, our job is, sometimes we do interventions. So we're going to get into some of the interventions that might be helpful to turn down the volume of the pain. But in terms of keeping the volume down, it's really about understanding the situation with education, understanding their thoughts, their fears, their beliefs. And a lot of times it's maladaptive or negative beliefs around their situation, catastrophizing perceptions about the future. And so refocusing that and get them going on some activity as well as mindfulness-based approaches. So that's kind of the first line, right? And then we add on psychology. And then another thing I know you're very keen on is nutrition and how that relates to pain.
Well, you are what you eat, as they say, right?
Right.
And I was fortunate enough that my wife has a background in nutrition, holistic nutrition, and I've benefited from that immensely. So she got me off of fast food mostly.
Nobody's perfect.
There's the odd cheat meal, of course, but intermittent fasting and healthy eating, and the importance of an anti-inflammatory diet. It's basically a Mediterranean diet. It's avocado, deep sea fish, healthy oils, olive oil, lots of vegetables, and so on.
Fruits and veggies. Yeah.
The body doesn't like inflammation. We want to decrease inflammation and eat health. So with a combination of intermittent fasting personally and eating my wife's generally great, not generally, but always great.
Careful, she might be listening.
You're going to edit that one out.
I got
you. All right, thank you. So this kept me, keep me going, and I try to pass that on to patients.
Cool. So in chronic pain, sometimes the pain is the problem. Like you say, it's been reclassified as a disease entity in itself. But stepping back to your wheelhouse, which is the interventional pain medicine, because a lot of times people will come in and they're in pain and they can't move, or they're in such severe pain, and there's going to be a psychological component of that too. Is there something that you can use to turn down the volume? Sometimes I use the analogy of an electric guitar with patients. And if anybody's ever been around electric guitar, they've got a volume and they've got a gain knob. And the gain turns up or turns down the sensitivity of the pickups. And so when we talk about centralized pain, we talk about having the gain volume, the volume is at 5, but the gain knob is at 10. And so you do a G chord and you get a big response. Whereas if you have the gain at 0 and the volume's still at 5 and you're able to reproduce the exact same G stroke, you'd get a nice pleasant bring.
Right.
So the stimulus is the same, but the response is bigger. So in situations where the gain knob is really up and we've got these big responses, this high pain level, what are tools that you use in your practice to manage these types of things?
Right. So to quote Spinal Tap, this one's at 11. Right?
This one's at 11.
That one's at 11. Right. And so to dial it back down again, and often there is an element of some arthritis or things going on. So there's medication, and of course there's no great medication, unfortunately, but some people respond better than others to certain medications. And if it's an inflammatory issue, then an anti-inflammatory should be used. But the problem with anti-inflammatories is you have a lot of issues in terms of stomach, GI issues, heartburn, blood pressure issues, kidney issues, interactions with medications like their blood thinners, for example.
Right.
So anti-inflammatories are often limited, especially in the population that have most chronic pain in the elderly. Then you have acetaminophen, which is great for managing fevers if you're sick, but it's not such a great pain medication, although some people do okay with it. But it's relatively benign unless you take too much of it, because it can affect your liver, so you have to be careful how much you take.
Right.
And it's also combined with a lot of over-the-counter medications, so be careful how much acetaminophen is in the other medications that you might be taking, because cumulatively it may be approaching toxic doses.
Wow.
And then you have, for nerve-related pain, you'll often hear about medications called pregabalin or gabapentin. Trade names would be Lyrica or Neurontin in Canada. And again, these medications are meant to target, they were first used as anticonvulsant medications, so treating seizures. And you're like, oh, why is my doctor giving me a seizure medication for my pain? This makes no sense.
Yeah.
So hopefully the doctors explained this.
Again, communication and understanding.
The idea is that just as in a seizure, the medication calms nerves. And the idea is it's going to calm hyperactive nerves that are inflamed or irritated or damaged because of the chronic pain.
Right.
So normalizing the conduction along the nerves is really what they try to do. But it comes again with side effects that often limit their use, especially if they are started too high a dose. So the idea is to start at a very low dose and then gradually increase them so that you can actually get the benefit of the medication without being interrupted by the side effects.
Makes sense.
But again, and it only helps a certain percentage of people. And then you have the antidepressants, tricyclic antidepressants like the amitriptyline or nortriptyline. And then
are these used to treat the depression associated with pain or to treat pain itself?
That's sometimes you can kill two birds with one stone. I hate that analogy because I do like birds. My son would be horrified because he even saves his worms and things from getting stepped on. But as an antidepressant, again, there's the tricyclics, and then there's the serotonin, norepinephrine reuptake inhibitors, and that's a big word. And we just abbreviate that to SNRIs, and they're similar to SSRIs, serotonin selective reuptake inhibitors, but the latter group, SSRIs like Prozac or sertraline, those medications are not. They don't really have the same effect for pain. They can manage depression, but not the pain side of things. But the SNRIs help both.
Okay.
So if the doctor hasn't really explained to you well enough why they're being put on one of these medications, they're wondering, well, the doctor just thinks I'm just depressed or anxious.
Making it up, it's all in my head type of thing.
But there is a rule for those, and how they work is by increasing the levels of norepinephrine and serotonin. The thinking is that in chronic pain, some people have suppressed levels or decreased levels of serotonin and norepinephrine. And by increasing them, it helps with the pain pathways, helps suppress pain more. Okay. But again, side effects, right? So dry mouth, antihistamine kind of side effects, blurred vision, stomach constipation, weight gain, and they all have potential side effects. So the PEER group, PEER, which is part of the simplified chronic pain guidelines issued recently from the Canadian College of Family Physicians. And they looked at a lot of the data and evidence behind which medications to use. You can find that online. If you, I guess we'll put in the show notes a link to that. Again, a lot of these studies are fraught with difficulties because the evidence is very low for a lot of these things. Just the studies, the groups of people they're studying all have some differences between them, and they're not all the same, right? So,
which is why a lot of pain patients have been on multiple medications, right? Because they've tried this, so it didn't help, tried this, didn't help. Sounds like you're saying that medication can be helpful in some situations, but isn't great long-term because of potential side effects, and is better as part of a more holistic approach, like we talked about, managing with movement and exercise. So it's not just if you have pain, take medications. That's kind of what I'm getting from you. You need a more holistic approach.
Right. And some people don't even, like to take medications. It's just something they don't want to do. And yet some interventions that we do to help with pain requires that you have tried and failed a couple of these groups of medications, which is
part of the protocol,
another barrier to management that is antiquated from our Ontario health insurance, and I'm sure other insurance programs across the country.
So you only have access to certain treatments if you failed at other things
first.
Right.
So it's ancient thinking about, okay, well, I would just assume that patients should be trying medications first, and then they can do a lidocaine infusion.
Right. So what's the lidocaine infusion for our listeners that don't know?
It's an intervention that helps to try and dial down pain by administering an intravenous bolus of lidocaine over a couple of hours. So
it's like you see in the TV shows. You got a bag up here and it's going into your arm.
Exactly.
Okay.
So and lidocaine is like an anesthetic, which if you cut your arm and you need stitches, you would get some lidocaine injected into the wound to try and numb it.
Tissue. Right.
And the same idea with when you have an intravenous of it is that it helps to dial down the pain again.
So you don't numb your whole body per se. You just kind of tone things down a bit?
Tones things down and often allows a great many people to be able to focus then on other things that will help them manage their pain and improve their function. The problem, again, is that patients, they feel better for a few weeks, 3 weeks, some people for 4 weeks, but the government only offers them every 2 months. Right. So we're sort of stuck again for that month of pain. So
limitations of access in terms of coverage for MOHIP. But what about injection therapies? Because you hear a lot about injection clinics. They've been in the news, sometimes positively, sometimes negatively. So what type of injections might people receive for chronic pain?
This is quite a quagmire right now because you have a patient who does have some inflammation, maybe some facet joint arthritis in their back, or some sciatica with a pinched nerve, who may benefit from an epidural. And so ideally you have an image-guided procedure done. However, there are a lot of clinics that don't use image guidance. So I'm not sure, where they're injecting. They call them nerve blocks, but I'm not sure what nerve they're blocking. And honestly, I'm sure I'm going to ruffle some feathers with this whole topic, but at this point in time, image guidance is not considered the standard of care, which to me is totally crazy, totally crazy. And in fact, if I wanted to be reimbursed for using image guidance, I would have, based on the guidelines from the insurance plan, OHIP, I have to first fail at a blind attempt. I would have to stab the patient with a needle blindly, but to me, it just makes no sense that you have to fail a blind injection first before you can actually bill for using ultrasound guidance.
Yeah, that seems strange to me because if you do an injection, you want to hit the target.
Reduce risk and you want to maximize benefit.
So Mike, pain is complex, as we've talked about. When it comes to medication use, how that links in, how do patients respond in terms of that medication side effects, the psychosocial approach, using nutrition, diet, exercise, movement, teaching people just about their pain and about their condition, how to become from a passive coper, fix me, to an active coper, taking control of their own pain. So if someone's out there listening, they've got chronic pain, maybe they're just taking medication, or maybe they're not doing anything, as you say, suffering in silence. We know that they need to understand the condition, understand some pain science, which we've talked a bit about today, think about their diet, think about getting exercise. A lot of times people are fear of movement, they're fear of causing harm or injury. So they don't want to, my knee hurts, therefore I shouldn't move my knee, or my back hurts, so I shouldn't walk, or my back hurts, I shouldn't exercise because it hurts my back.
This is an interesting area because exercise and motion is important. However, people are very fearful of causing more damage or aggravating their pain. You can't just say, oh, you got to exercise, you got to move, you got to get out there, get out of bed. Patients need parameters, and pacing is very important. So you want to say, well, how long do you walk before you go from a 5 to a 7, for example? And they say, okay, 5, 10 minutes, say 10 minutes, and say, okay, well, so take a certain percent, 50% of that, and see how long that is, and then divide it by 2, so you want to go there and back. And then just gradually build it up, gradual progression.
And if you link that with this fear and you understand that hurt doesn't equal harm, right? Going to pain, but not through pain, using that positive psychology, right? Using a cognitive behavioral approach, overriding that primitive brain by saying, hey, you're not causing harm or injury. It hurts, but you're okay as you're gradually building up your tolerance. That's kind of the approach you take.
Hurt doesn't necessarily mean harm. Your body's not going to crumble. And it's replacing that, again, that whole danger, the cognitive side of things with safety.
Right.
Safety.
Or putting a positive flip. You're making things stronger. You're making things more tolerant.
Right.
Building up capacity and load and tissue tolerance.
And you want to find something that they enjoy doing too.
Right.
That's important. Whether it's swimming or biking or some activity. And even if they can't get off the couch because they're having pain, like say, well, you can move around on the couch. Start by moving your arm around on the couch. Start wiggling your body around on the couch a bit, and then just gradually build up from there. Just really start with small steps.
That's a really good tip. So if people I often with neck pain have people do movement, and I like to encourage people with neck pain to do movement in the shower. Human tissue is more pliable, more flexible, more stretchable, kind of looser when it's warm than when it's freezing. If you think about texting on your phone in a cold day, you're missing keys and it's stiffness, right?
Whereas I miss keys on a normal day.
But usually things feel more loose and pliable when they're warm. So you're already in the shower anyway. So I have them turn to their back to the shower and just start with some gentle range of motion movements. To pain, not through pain. So using that analogy of a little bit, going if 0 is no pain and 10 is chop your leg off with a blunt axe, up to including a 4, but not beyond. So you're not forcing. You're going to that symptom, but not beyond, while understanding that you're not causing harm or injury, using that prefrontal cortex to override that primitive brain response. You can use that from a number of things if you're a listener. To pain, not through pain, up to including a 4 or 5, but not forcing it, and gradually building your tolerance up over time. Is there any other tips that you'd give for a person in terms of chronic pain?
Well, try and prevent it. Don't leave things too long if the pain is not improving. And you want to engage your family doctor early and start working with the exercise and the mindset tools and the nutrition. And prevention, of course, is huge as well. Once you're concerned that it is becoming chronic, past 3 months, or not past normal tissue healing time, then you really want to engage with a multi-pronged approach. And that involves, again, mindset, which is huge, and nutrition, which is huge. So to get rid of that, Big Mac and those donuts from Tim Hortons and sugar is just everywhere, right? So prevalent, and it's just so inflammatory. And then exercise in a way that's important to you and comfortable. Those are very important elements of a holistic approach. And then occasionally you need to dial down that pain, and that's where I come in. And what I do is a lot of image-guided procedures. And then there are other options as well. And there's another medication that's coming on the radar that's interesting to be aware of. It's called low-dose Naltrexone. Naltrexone. And Naltrexone is a medication that's typically been used for managing alcoholism and even gambling issues. But it's used for those issues at 50 milligrams, usually 50 to 100 milligrams. But we're talking about using minuscule doses. So that's why it's called low-dose Naltrexone. So we're talking about 1 milligram to 6 milligrams, or even less than a milligram, by activating your body's own pain chemicals and endorphins and enkephalins. There's not a lot of solid evidence for it yet, but it's something that's just on the radar as a new tool in our toolbox. Certainly opiates are a real quagmire that we want to avoid if we can, although they are necessary in some people. It's a whole other discussion.
Yeah, it's a big topic.
But there are benefits if everything else has failed in certain populations in non-cancer pain. However, there are problems with opiates, as we all know, in terms of it's called pain sensitization, opiate pain sensitization. So too much opiates can actually increase your pain. There's dependence issues. We have to increase the amount to get the same effect. There's constipation, there's fogging, there's all kinds of problems with opiates. So we really try to avoid opiates through all these other techniques if at all possible.
Right. Mike, I've heard you say a quote. I can't remember who said it, but it's something to do with pain. What is that quote that I've heard you say before?
So I have it on the wall in my office there. I think it's a quote attributed to the Dalai Lama, but then there's other people that are claiming that they said this, and who knows. But
it was me. I said it first.
I just think I said it too. So we can all have mistakes. But the quote is, remember that pain is inevitable, but suffering is optional. And this isn't to minimize the experience of pain for sure, because pain is there. Pain is real. But the point is to not underestimate the power that our mind has over how we interpret painful experiences. Pain signals from the body is like advice to the brain, right? This is advice.
Right.
And what we do with it depends on our understanding and beliefs and everything we discussed today, our motivations, the situational context.
Mm-hmm.
And so, using skills like cognitive behavioral therapy, pain reprocessing therapies, and so on, mindfulness-based stress reduction and meditation practices, all of these things can help to try and dial down that pain alarm system that we've been talking about, replacing the danger fear cycle with a sense of safety. And that's really what we have to really emphasize that more. We need more resources that we can provide for patients who can't afford psychologists and therapists and so on that we really need to employ in these endeavors.
Excellent. So Mike, taking everything we've talked about, what would you like to see the future of pain management be?
A funded, holistic, multi-pronged approach to management, more access across the country to everybody, so marginalized communities and certainly remote communities, Indigenous populations and low-income people. And across Canada, the average wait time for an interventional chronic pain clinic, they're usually urban-based, and the average wait time is about 6 months across Canada to get into one, but can be as long as 2 years in New Brunswick. Wow! So there's a huge range. If you're not chronic already, you're certainly chronic by the time you get into the chronic pain clinic. Yeah, definitely. So increasing access to all of these therapies that really help, a decreased emphasis on medical management and increased emphasis on the pain psychology side of things. And there's actually data that a 3 to 5% reduction in chronic pain can save the government and system $1.2 to $1.9 billion over 10 years. The long-term benefits it's a win-win situation for everybody, for the economy, for the individual. And so you just have to put the money into it and provide the resources that are necessary, and we can make gains all across the board. Wow, desperately needed right across in Canada and across the world for sure. Thank you, Mike, for your time today. Now, I know you have your own website and a podcast. Why don't you tell me quickly about that for our listeners that might want to access that resource? Thanks for the opportunity. I have a podcast that we've just launched called Pain No Pain. So I do this with a colleague and friend of mine, Dr. Sev Perlman. We have a website called painnopain.com. I'm adding resources to it gradually. It's a work in progress, but painnopain.com has some resources. And our podcast, which you might want to also check out. We have good cop, bad cop kind of a vibe going there, which is kind of fun. Okay, cool. Well, thank you again, Mike. It's been excellent. Hopefully our listeners have learned a little bit about chronic pain and maybe some tips and tricks that might help them manage their own conditions. Thank you for joining us on Eat, Move, Think. Thanks.
That was our Move host, Dr. Andrew Miners, Medcan's Clinical and Product Director of Sports Medicine, Therapy, Rehabilitation, and Fitness, in conversation with Dr. Michael Wansbrough, Medcan's Medical Director of the Pain Management and Recovery Program.
We'll post episode highlights and links you can visit on our website, eatmovethinkpodcast.com. Follow Medcan on Twitter and Instagram at MedcanLiveWell.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com.
Eat Move Think is produced by Ghost Bureau. Jasmine Ratch is managing producer. Social media and strategy support is from Chantal Gertan, Andrew Imex, and Emily Bozick, and I'm executive producer Christopher Scholgen.
We'll be back soon with a new episode examining the latest in health and wellness.
This podcast is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with the specific information highlighted. Any third-party links are not endorsed by Medcan.